Boy, oh boy. Well, originally I was going to be talking about coag reversal, but as it turns out, that ballooned into everything that you need to cover in a neurocritical care fellowship all in 40 minutes. So I hope you guys can write fast. All right, let's see if we can advance the slides. Just some disclosures real quickly. Nothing that I'm going to present here has anything to do with any of these companies that I've co-founded. So, all right. So to start, hemorrhagic stroke subtypes and etiologies. Okay, we have intraparenchymal hemorrhages, and there is the hypertensive kind. And when we break down the hypertensive kind, the most common hypertensive type of stroke is a putamental hemorrhage. It makes up about 70% of the strokes. Okay. Thalamic strokes, they're roughly another 15% or so. Pontine strokes, about 10%. And cerebellum, they quote anywhere between 5 and 10%. So when you think about hypertensive strokes, these are the most common causes or likely locations of these hypertensive strokes. Not causes, but locations, anatomically. Now, lobar strokes are different. And they can be a lot bigger, and they fill like basically a whole lobe of the brain. And so when you think of those, you usually think of those types of bleeds that are associated with, it doesn't have to be Alzheimer's, but definitely amyloid angiopathy. You guys heard of that before? Yeah? Okay. So amyloid angiopathy is oftentimes associated with dementia. These people will have bleeds multiple times. If you looked at an MRI of their brain, you would see that after the big hemorrhages have gone away, you'd see all these little plaques jaunes. You'd see all these little orange things, these orange plaques that you would see. On an MRI, they just look like some changes in the susceptibility, or they call it susceptibility artifact, okay? But when you look at it on a dissected brain after the fact, they have like an orangish, brownish tint to them. And it's basically the hemosiderin deposits. And they have all these small hemorrhages. Some of them end up being really big hemorrhages, and it can be a real problem, okay? Venous hypertension. You guys ever seen these venous strokes? Yeah. They don't follow an arterial distribution. That's what makes them different. See, all the other stuff that I kind of showed you so far didn't necessarily follow an arterial distribution either. But when you think about these types of hemorrhages, they happen because you have an imparting force going in through an artery, but the venous side of it's blocked off. So what happens is those little capillaries, they rupture, right? And then you end up with this type of a hemorrhage. What kind of patients would you expect to see that would have this sort of a type of stroke? So the first ones we covered were hypertensive ones. We gave you the 4, right? Then we went ahead and covered lobar hemorrhages, oftentimes associated with amyloid angiopathy, right? And now we have this type of stroke, a venous infarct. These are people that are hypercoagulable for some reason. So people that are on estrogen-containing, what do they call it, oral contraceptive pills. People that are overweight, I've done that. That's a problem I've had recently. Yeah. Those are the types of things you think about for venous hypertension, okay? Okay, hemorrhagic conversion of a stroke. So a regular person has an arterial infarct, and you can see in this case what makes this one look like that. Do we have a pointer, a laser pointer?
On the upper right corner.
Upper right corner, got it. Well, never mind. What we can do is, we can just talk about it. It's okay, it's all good. If you look at the area that's really dark, okay, what distribution is that? What arterial distribution does that look like to you? Middle cerebral artery, is that what I heard? Yeah, right? And so now what you're seeing is you're seeing some scalloping or little hemorrhages that are inside of that MCA infarct, okay? So that's a conversion of an existing stroke, all right? Now, some smart person in the audience is probably going to say, I don't see a ton of shift with that. How do you know that that's a hemorrhage? I can honestly say that in this picture, I can't tell for sure. But if I were to have a cursor, I could put a cursor on it and do a point analysis, and I would look to see how many Hounsfield units that is. Hounsfield units really aren't a unit. They're actually named after Sir Geoffrey Newbold Hounsfield. Hounsfield was the guy who invented the CT scanner. It's actually a unitless number. It's called the attenuation coefficient for anybody who's interested in that sort of stuff, okay? But they named it after him, right? It was originally, they were called EMI units before they changed the scale. Anybody know why they were called EMI units? This is actually great history. Do you know who founded or financed the development of the CT scanner originally in Britain? Because that's where it was, I mean, that's where Hounsfield was from Britain. He was a radar guy. The Beatles. And the Beatles, the company who actually did all of their music stuff was EMI, or Electrical Musical Instruments, or Electronic Musical Instruments, something like that. And so they were called EMI units originally. And then when they revamped it years later, they named it after Hounsfield. Anyways, I know I've digressed. Little ADD moment there. Okay. So, when you look at this, you see there's an MCA stroke. If you put a cursor on it, and if it's like around 50 Hounsfield units or so, it's probably a hemorrhage, okay? If it's a lot more than that, it could be contrast that's kind of leaked into that area. So if this person would have just had some IV contrast beforehand, or if they had just had an angiogram beforehand and they saw this, that super bright component, which is kind of, I can't point to it, but imagine that I was pointing to it. That really bright part might be contrast, I can't tell. One way to really be able to know is when you're scrolling through the images, look to see if there's any distortion as a result of that, right? If it's blood, it's going to occupy space. If it's contrast, it's just staining it. Does that kind of make sense to everybody? Good. Okay, subarachnoid hemorrhage. Another type of intracranial hemorrhage. What's the most common cause of subarachnoid hemorrhage? Someone say aneurysm out there? Actually, you know what the most common cause of subarachnoid hemorrhage is? Tripping over your own 2 feet, like climbing on the stage here and taking a nosedive. By far and away the most common cause. But if you got rid of the trauma side of it, the most common cause of subarachnoid hemorrhage from a non-traumatic purpose would be an aneurysm rupture. And this one, I remember I had a teacher when I was in medical school, and this goes back a lot of years now because I'm already getting kind of close to retirement. But when I was going through medical school, there was this really awesome radiologist, and Batman was big, like the Batman with like Michael Keaton, you know, that Batman. You guys know that? Like the younger people here are like clueless; they have no idea what I'm talking about. And when he saw this, because of the way it looks like the wings of a bat, he says, when you see the wings of the bat dressed in white, in a white suit, the bat is dressed to kill. And that's how I will always remember subarachnoid hemorrhage. He was a phenomenal teacher. I think he was Colombian. He had this great accent. He was super awesome. And the way he said it, and it'll never leave my mind. So, subarachnoid hemorrhage almost always caused by an aneurysm. And then intraventricular hemorrhage. Now, these are almost always associated with another type of hemorrhage, right? So they could be because of a subarachnoid hemorrhage. They could be because of intraparenchymal hemorrhage. They sometimes are truly spontaneously in the ventricle, and I tried to find a picture that has that only. Because if you look at this, you don't see anything from the thalami here, you don't see anything elsewhere. So just keep in mind that's another type of intracranial hemorrhage as well. Okay. All right, scoring systems. ICH score. Still have to cover this too briefly. Okay. So the ICH score, why do we have it? The idea is to try to predict what mortality is going to be and what functional recovery is going to be. And so if you looked at it, the range is 0 to 6. And when you talk about mortality, if you had a score that was 1, your 30-day mortality is really small. It's like 13%, right? And if it was 4, it's like 97%. Now, why do we have to predict that kind of stuff? Well, sometimes we need it for certain things that we're going to do. Sometimes it helps with family conversations. You know, things to keep in mind, in particular, you know, they always say age less than 80, age greater than 80. Age is just a number. It's an important number, but really what your physiology is going to really describe that. And what I mean by that is I've had people that were in their 80s that were out golfing, that were doing all kinds of stuff, and that were super active. And I've had people in their 50s who were very, you know, not active and very sickly and you know, couldn't outperform the 80-year-olds. So it's something to keep in mind. Okay, now modified Rankin score is used for disability determination, and I don't want you guys to think they directly correlate, even though they use a scoring system from 0 to 6 as well. Okay, so both scoring systems are 0 to 6, but don't think for a minute that you can actually just overlap them one for one, because that's not entirely true. Okay, diagnostic assessments. All right, the first and most important thing you're ever going to do that's going to be very important is going to be your physical exam. Always think of your ABCs first. I know that when you do ACLS, or if you do ATLS even, they talk about the ABCs, and everybody kind of gives it a lot of thought. They test for their ACLS certification. They get the nice little card. I just did mine last week. and you say, oh my gosh, I'm all ACLS certified, this is great, and then they forget it. Oh, they didn't forget the ratio of compressions to, respirations. They didn't forget the drug that they had to give for, VFib arrest and how they're going to shock them and all that. No one forgets that stuff, right? What they forget is the whole airway part, the most important part. If you've got a guy who is not performing well and you're like, the first thing you're thinking is, I want to scan this guy's head and look for an intracranial hemorrhage. First thing you should be thinking is this guy got a stable airway? Right? I can't tell you how many times someone will get that sent down to CT scan, and then all of a sudden you hear a code blue radiology, and that's like the worst thing you could ever hear, because they don't have anything down there to help for you. You know what I mean? So you'd be much better served to go ahead and look at that same patient before you send them down. If they're declining that fast, put a tube in them, then get them scanned right away. Okay? Very important. All right, for your neuro exam, eyes are important. Are they deviated? Now, if you have a stroke, which side do they deviate to? They're kind of the same side, right? So if I have a left stroke, it goes to the left side, right? Interesting. Why is that? Anybody know? Yeah, well, you said weakness of the muscles. Maybe it's innervation of the muscles in particular. So your frontal eye fields sit in the frontal lobes, Brodmann's area 8, right, on either side. So if you take out this side, so you have tone from this side and no tone from this side, they're going to go to the ipsilateral side of the stroke. That's pretty easy, right? Well, what happens if the guy had a stroke? If you're looking at this person's looking to their right, right? What if this person has a stroke on their left? Oh, seizure. That's right. Someone just said well, a few people said the right answer. That's right. Could your stroke patient be having a seizure? Yeah, absolutely. So again, your physical exam is going to drive what you're going to be doing next, right? It's not just the imaging. Pupils. Now, I could show you this same patient here. I've got this one patient right here. I'm going to tell you that this particular patient had what they call a blepharoplasty. You know what that is? She had an eye lift. Yeah. How many ladies and gentlemen in the audience have thought about doing that? A number of hands? Okay. All right, so when you look at this, which is the abnormal pupil? Kind of hard to tell, huh? Okay, well, let's look at it in two cases. Let's look at it if most people always go and say the left pupil is the abnormal pupil. Okay, and that may work out to be true, right? If you had a person who has got their eyes open and you see a fixed dilated pupil, right? Is it a blown pupil that is related to something surgical at that moment in time? Is that person herniating? Might be something surgical, but it's not herniating, right? Patients herniating, they don't go ahead and have their eyes wide open and they're talking to you and everything else like that. This is a great story. I was chief resident in neurosurgery, and I got a call I was in the operating room. The intern was running an emergency and taking a patient to the operating room, so the emergency department called me for a guy with a blown pupil. And so I run from the operating room, which my attending at the time was, he had a lot of colorful anecdotes and used a few words that were very hilarious. But anyways, I had to run out of the operating room to go check out this patient while we were doing the spine case. And I run past the trauma bays. Trauma bay 1's got nobody in it, trauma bay 2's got nobody in it, trauma bay 3's got a guy sitting up. And the ER or ED, it looks, basically empty. And so I go and I say, hey, where's the guy with the blown pupil? They say, oh, he's in trauma bay 3. I'm like, oh. So I walk back and I'm having a conversation with him. This is interesting. And so as I'm talking with him, I find out he has a glass eye. So history is important. But if the guy is talking to you and he's got a blown pupil, he's not actively herniating. Okay? What could cause a blown pupil on that side if he's not herniating? A PCOM aneurysm that hasn't burst yet. I mean, I guess it could have burst, but in this case, they'd be cringing and doing bad things. But you could have a PCOM aneurysm that's pushing on it. There's a lot of other neurological reasons which we won't get into because it's outside the scope of this talk. But a PCOM aneurysm could do that, and that's assuming that the left eye is the bad eye. What if it's the right eye? I told you this lady had a blepharoplasty. She had an eye lift. People who know me pretty well will know that when I get tired, I have one eyelid that tends to droop more than the other one. It's an interesting problem. But most people don't have that issue. So if I see a young woman, let's say in her early 40s, who comes in, who had COVID or something else, was coughing, 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 and all of a sudden had a droopy eyelid and a small pupil on the right side, what would I be thinking about? Somebody? What was that? Myasthenia. Well, that's an interesting question. I don't know that with myasthenia I would see a unilateral pupil. Yeah. What common things being common? What if I told you it was a 27-year-old female who was in a car accident and had a seatbelt injury across her neck? Carotid dissection. All of a sudden everybody got that one, right? But you could have a coughing fit and still have that and have a carotid dissection. In this particular case, this particular patient, actually the right eye is the one that's bad. But she just happened to have bigger pupils on the left. And I thought that was an interesting sort of finding. That, the room was a little darker, we lit up the room a little better, but I thought that was something that's important to show up. So visual acuity is the next thing you're going to want to know. What's their vision like in that eye, right? And commands and language following. Those are things that are going to be important. There's a lot that goes into following commands, right? Your ear's got to pick it up. Then it's got to go from your inner ear to the cochlear nerve, to the vestibular cochlear nucleus, right? And everything, the thalamus is responsible for the relay stations for everything sensory except for smell, right? So it's going to have to go then from the vestibular cochlear nucleus, the eighth nerve nucleus, it's going to have to go to the thalamus. And where's that going to be? In the thalamus. Medial geniculate body, right? The medial geniculate body is going to go to Heschel's gyrus, right? So if this is your right hand, that's your left brain. Funny how that works out, right? This is your temporal lobe, this is your occipital lobe back here, your parietal lobe here, your frontal lobe here. If you were to peel it open and look right here, Heschel's gyrus is right inside there, superior temporal medial portion of the temporal lobe. And everything up to that point is tonotopically matched out. Everything works in order of frequency. But then when it goes from the most mesial superior portion to the superior lateral portion where Wernicke's at, all the little fibers crisscross over there and they change their position. And that's Wernicke's area. From Wernicke's area, you then have to broadcast around the arcuate fasciculus, right? Overlying it's under the angular gyrus. Superior longitudinal fasciculus all the way across to the frontal lobe, where then you will do your motor stuff, including your motor planning, which will happen in SMA and the premotor area, and then out through the motor cortex and down. And all that processing has to happen for you to follow commands. And all of a sudden, when you look at the Glasgow Coma score, you think to yourself, they only gave you 6 points for following commands? With all of that evolution and incredible processing power? We have rooms full of computers using gigawatts worth of energy, and this is what we gave is only 6 points. But at any rate, it's important to be able to follow that, okay? Sensation, right? Reflexes. Brisk reflexes don't usually happen right away. If you're going to have brisk reflexes, that usually is something that happens a week or two out, maybe a little further out than that. And then, of course, you're going to look at their heart and their lungs. I had a terrible case just about a month ago or whatever. The person came in, and she was having strokes. And, she came in, she had these splinter hemorrhages, and her fingers were turning purple, and she had a splenic infarct, and her kidneys were failing. It turns out she had a bunch of clot there. This poor woman was actually very hypercoagulable as a consequence of a cancer that was undiagnosed. And she was shooting clot all over the place. So, listen to the heart, listen to the lungs. She had PEs. She had some terrible murmur as well. And then, of course, you have your imaging. And with your imaging, you have both CT and MRI. Now, you'll look and you'll see here, we have a regular CT on the left, and on the right side, we have a hemorrhage as well, and an MRI, and it's a T2 type image. T2 is very sensitive to blood, right? It's actually very sensitive to anything that's paramagnetic. So iron, gadolinium, anything like that, right? And when you have all of that blood, and you can see this person has a bunch of black dots all over the place, right? Makes you kind of wonder if this person has either superficial siderosis, because it's at the surface more so than it is deep, or if it's amyloid angiopathy, again, rearing its ugly head, right? But I wanted you to be able to see the two things side by side, okay? And then devices. We could place EVDs or lumbar drains or ICP monitors to try to measure pressure, to try to alleviate pressure. And we could hook up EEG. We had talked about that person's pupils and we saw that they were off. We talked about, now if they're having seizures, they're going to have big pupils, but they'll be reactive. But if they're actively seizing, their pupils get kind of big, right? But the gaze deviation issue, right? If it doesn't deviate in the direction you'd expect, hook them up to EEG, let's see what's going on. If they're not following commands and they were before, or their exam is vacillating, very strongly consider using that as a diagnostic tool to treat. Okay, blood pressure management. Oh boy, this has been all over the board. Kind of like the blood pressures that we treat in our patients, right? Okay, so in 2013, New England Journal of Medicine, they published an article saying that getting people's blood pressure less than 140 but greater than 120 millimeters of mercury had modestly better functional recovery and possibly slight improvement in mortality and major disability, all without actually having injury to the kidneys, which is great. But less than 120, if you're too aggressive, then you take hits to the kidneys. And so that's really a hard one to do. How do you shoot for, 120 to 140 when they come in with a blood pressure of 220? Right? So then they've studied that afterwards. Oh my gosh, you mean the AHA has guidelines on this? So they reviewed a bunch of different articles. And in 2015, they recommended if their blood pressure is 180 to 220, lower them to 140. But if their blood pressure is higher than that, you might actually want to go a little bit higher. And so then there was an article that followed this up in 2016. Rapid correction of systolic blood pressure could be associated with worse kidney function. And so they found that if your blood pressure was 110 to 139, it was associated with more renal adverse events. And if it was 140 to 170, there was no change. So again, the 140 number kind of keeps coming into play over and over again, right? And what they noticed in the original article, which was less than 120, has more renal events. Well, that correlates with the 110 to 140. If you're less than 120, these things do kind of overlap. If you actually look at the history of all of these articles, they actually do kind of work out. And so, where I was at before, we would really shoot for 140 for our blood pressure. Where I'm at now, they shoot for 150. Is there a magic number there? No, not really. But the problem is I can't just go ahead and ask the nursing staff to hit 140 on the dot. I don't want 139. I don't want 141. I want exactly 140. That's not going to fly, right? It's not realistic. So the concept here is let's just say, is 150 that much different? If you have someone who has an unprotected aneurysm, you may change your mind and want them a little lower. But barring that, it's probably not necessary to do that, right? And if they're greater than 220, we have a target of 180 first. Those people are just a little more volatile as you bring their blood pressure down. And so we usually start with 180 and then we work our way lower than that. Because, once they're less than 180, then their blood pressure is no longer, 220 anymore, right? So then we can go ahead and work our magic. Okay. Now, the biggest terms that we've been seeing a lot of is bundled care. And I think that we've been doing bundled care for a long time. And at my former place, we did this. We didn't call it bundled care, but the reality was we followed stuff that already had existed in the literature before. This particular article on Interact 3, it's the bundled care protocol for acute intracerebral hemorrhages, right? Recommends a blood pressure of less than 140 and a blood sugar of 110 to 140. Now, I will say that blood sugar range is a little lower than what we would normally shoot for. We usually shoot for less than 160 based on the NICE sugar trial. Okay? We don't want intensive blood sugar management, and that's what NICE sugar trial actually showed, that those people did worse. If you try to get their blood sugar 80 to 100 versus just less than 160 and above 100, which group did better? The 100 to 160 group did better. And why did they do better? Because they didn't have as many hypoglycemic events, and that's a lot worse. So we don't want that. But 160 is a reasonable number. Anyways, in this particular trial, the Interact 3 trial, they shot for 140. There's nothing wrong with that. The key is they're not really looking to go less than 110, and that's fine. No fever, less than 37.5 centigrade. And make sure that you reverse coagulopathy appropriately. Right? So when you think of bundled care, this is the bundle. It was these things put together. Right? And the goal here, and what actually showed in Interact 3, is that you have improved functional outcomes for patients with acute cerebral hemorrhage. So this is just an example of bundled care. Again, remember that everything we're going to be going over here is stuff that's in the literature. You don't actually have to meet every single requirement, but think about what's been done, how many hundreds or thousands of people have been looked at. You can look at meta-analyses where they put a bunch of papers together and they study it. It's just important to think about what your options really are. Okay, now here's what I was originally tasked to talk about, and I'm going to make a shameless plug. Journal of Emergency Medicine 2022, myself and a number of people at UW, we published an article on the reversal of everything coagulopathy. So every medication at that point known to man or woman, right? Any coagulopathy related to stuff not related to medication. So people who would have various different genetic coagulopathies, et cetera. This is just a sample of the tables. I would suggest that you try to get a copy of that article. And the reason why I say that is because, not because I want you to read the article, because really it's really boring. I mean, honestly, if you have insomnia, read the 3 pages. It's only 3 pages of the article, right? But what you want to have in a pinch is the tables. And there's a dozen tables there, and they show you the anticoagulant, the half-life of the anticoagulant, the duration of action, because that's something that goes beyond what the half-life of the anticoagulant is. Is it reversible or not? If it is reversible, what are the reversal agents? If you give the reversal agent, what's the reversal agent dose? What's the reversal agent half-life, right? And what labs are you going to use to follow it? The tables are going to be everything for you guys. You go ahead and you look up the table, you get to where you need to. This is my patient, this is what I have, this is what this guy is presenting with, boom. This will make your life a lot easier. This is just one table from the article. And the reason why the tables are helpful is not because you need to, everybody was worried when they saw this part of the talk. They said, oh my gosh, this looks complicated. And I'm like, you know what, it's okay. You don't have to memorize this. There's no board exam afterwards. It's fine, right? The goal isn't for you to really have to memorize it, but I want you to realize there is an absolute mechanism for everything, okay? And it's important because when we talk about reversal strategies, you need to have a basic understanding of what that is. But if you don't have a basic understanding, that's okay. Go to that one article, look up the table, find out what it says in there, and then you'll be able to know exactly when you give something to reverse it, what's it mean? Like people will say, oh, I gave the guy TPA or now TNK. And TPA lasts, 30 minutes in the blood. So why do we have 24 hours that we have to be worried about bleeding? Anybody know? I hear some mumbling. Nobody's brave enough? Okay, that's fine. So if you gave somebody TPA, even though the drug is cleared really fast, what does TPA stand for? And this is the reason I'm not going with tenecteplase or TNK. TPA stands for tissue plasminogen activator, right? Plasminogen activator. That means you take plasminogen and you turn it to plasmin. And what does plasmin do? It's like a little Pac-Man guy, right? And it goes around and it lyses all these little fibrin clots all over the place. TPA is gone within 30 minutes, right? Under normal circumstances, you clear it pretty fast. TNK, 130 minutes. But the action of plasmin, which has been now activated, is up to 24 hours. You see that? So the drug is long gone. Same thing goes with aspirin. I take a daily aspirin. You know, when I was a kid, I thought, because, being the shortest Jewish kid in school, I can tell you that you get picked on, right? That's just, it's going to happen. And so, you get in a fight or whatever, and it happened. I'm from Chicago, right? So, like a place like this is like home to me, And I always thought that I was genetically tough because, you take a hit to the chops and, your lip would swell up, but mine wouldn't bleed. But the other guy would end up with a bloody nose or whatever, and I thought, geez, I'm just genetically tough. That's the way it is. They just build us, the Meadows, they built us really able to not bleed that easily. As it turned out, when I got to medical school, I realized that there was a much higher incidence of coronary artery disease and stroke in my family because we are prone to being able to clot. So I started taking a daily aspirin. And now when my sister goes ahead and hauls off and hits me in the shoulder, I actually will have a bruise. Whereas before I really wouldn't. So when I take an aspirin, how long does that aspirin last in me? An hour maybe? Hour and a half? But how long is the effect on the platelets from the aspirin that I've taken? 5 to 7 days, right? Exactly. Right, so when we talk about what actually is the half-life of the drug versus when the effect is gone, they're two different things. I just want you to be very aware of that. That goes for a number of medications that we'll cover. This is just going to be some very brief stuff. When we talk about heparin, Anybody ever wonder why heparin works the way it does? It's a dextran. And I don't know if you guys ever used hetastarch. Are any of you old enough to remember hetastarch as a colloid that you would give to supplement blood? A few people raised their hands. Yeah, it's old school, man. You know why you couldn't give too much hetastarch? Because it works like a dextran, and all of a sudden these people would become coagulopathic. So that's why you don't really see hetastarch too much anymore, because if you kept pumping them through full of that instead of albumin, then all of a sudden you'd find that they were more prone to bleeding, right? And how does that work? It activates antithrombin, or antithrombin 3. And if you see that, and again, I'd like to be able to point, but it struggles here, I think. Okay, I have to pull this tape off. Aha.
Secret.
Am I going to shine this green light into somebody's eyes? You see the antithrombin over here? Okay, great. So, antithrombin works on factor 10A and it works on factor 2A. So it works on 10A, which you guys are aware of, and it works on thrombin, which of course antithrombin, go figure, right? So, if you have a heparinoid and it works, a regular unfractionated heparin, it's going to work on both of these. But it's very interesting. The heavier the heparin molecule, boy, that got loud awful fast, the more it's going to work on antithrombin 3 to affect thrombin. The smaller, the lower the molecular weight of the heparin molecule, the more it's going to work on 10A. Okay? So when you go to give somebody a reversal agent, you have to figure out when you're going to reverse that, how is that going to work? Because as you move further along with the low molecular weight heparins, oops, I went too far. How do I go back? Let's go back. There we go. This, on the low molecular weight heparins, is going to really focus over here. And when you get to something like fondaparinux, you guys have heard that? That's like that's like a synthetic. That's like the lowest molecular weight stuff. So really, it's going to have no impact over here. So you're going to be looking at 10A levels for all of it. Right? Oh my gosh, there's fondaparinux. Okay. Now you can directly inhibit factor 10A. Oh, I should say one more thing, by the way. There's a reason why with general heparin, unfractionated heparin, and is different than low molecular weight heparin, which is then different with fondaparinux. With general, we give an unfractionated heparin, there's a lot more there's a lot less low molecular weight heparins and a lot more of the higher molecular weight heparins in there. Protamine works, right? Protamine basically ionically bonds the heparin molecules. And again, heparins are different weights, different molecular weights. The smaller ones, though, it doesn't ionically bond so much. So that's the reason why, since when you give unfractionated heparin, it's mostly the higher molecular weight heparins, when you give them protamine, you can actually reverse that stuff pretty fast. But with the low molecular weight heparin, since it doesn't really bond that easily, you're not going to have as much of an effect. Right? And so the solution to that could be something like andexanet alpha, which is super expensive and it takes like 2 hours to get into somebody. Or you could say, you know what, screw it, I'm just going to replace the factors. Right? I'm just going to go ahead and I'm going to replace factor 10A. Or factor 10 rather, not 10A, but factor 10. So I have a whole bunch of factor 10 left so that the effect that I've had on killing the factor 10A that I had already with my low molecular weight heparin or my super low molecular weight, which is fondaparinux, the effect on that is going to be modified because I've replaced it by replenishing factor 10 so much. And for that reason, you can give PCC, right? Prothrombin complex concentrate. It's the 4-factor one that we use these days, right? Okay, you don't care about all the other factors that are in there, but the factor 10 that's in there is going to be useful for you, okay? Same thing kind of goes when you're giving direct 10A inhibitors. So let's just say I keep hitting the wrong button here. If we were going to go ahead and we look at this right here, if I have a direct factor 10A inhibitor, I'm skipping the antithrombin right here. I'm going straight to this. Right, I'm going to block this right here so that if in this whole chain, this whole cascade, I give it like a masquerader. I give it something that's not supposed to be there so that it blocks the cascade from happening. The way to override that is to just give a lot more factor 10. And then there's direct thrombin inhibitors. It's like, well, geez, if I can hit this, maybe I can hit that too. And that's these guys right here. It all started with leech spit. That's what this is. Okay? All right, that's how it thins you out. And then you have coagulopathies related to aspirin, right? The coagulation cascade, oops. it's an issue that you have to deal with here. So what happens? We give them something that blocks cyclooxygenase. Now, you've heard of COX-1 and COX-2. Those of you who are older may have some arthritic issues, and you may have liked Vioxx or Celebrex. Remember those? They were voluntarily removed. At least the Vioxx was voluntarily removed. I think Celebrex might still be available. One of them is still available, but it's not used that often anymore. The reason why they came out with this is they said, well, we can just directly block cyclooxygenase 2 because COX-1, cyclooxygenase 1, is mostly responsible for the antiplatelet effect. And so all these people that have GI bleeding and other problems that they're not supposed to have, we can give them Vioxx or Celebrex, and their arthritic conditions are going to get better, and they won't have the bleeding risk. Well, as it turns out, it went the other way. They had an increased risk of stroke. They became somewhat hypercoagulable, so that's why they got pulled from the market. At any rate, if we block cyclooxygenase with aspirin, or quite frankly, temporarily with another agent like your ibuprofen or your naproxen or things like that, ketorolac, if you block them right here, your prostaglandins won't get made, and if you don't make those prostaglandins, then the thromboxane synthase doesn't get kicked on to make TXA2, right? Thromboxane A2. If you don't have that, then you can't go ahead and make your platelets coagulate, right? So again, we block this temporarily in a platelet. Well, it's permanent in a platelet, but the drug itself is only there for, maybe a couple hours. But the effect of it is going to be there for a lot longer. It's going to be there for the life of the platelet. So clopidogrel, prasugrel, and ticlopidine, they work with this ADP receptor right here. Right? And they go through a cyclic AMP secondary messenger system, right? And if we're going to measure those, we'll measure P2Y12. On the previous slide, if we were going to go ahead and measure what happens with aspirin, we would use collagen epi, or the Verify Now thing that you guys have seen, right? You're thinking, when we talk about what that means, the P2Y12, we talk about platelet reactivation units, we talk about collagen epi, we're talking about things that we can do to stimulate clot formation. And so if we specifically pick a particular aspect of clot formation, because we know how these systems generally work, then we can more specifically identify which drug is the culprit for the person's coagulopathy. Okay? So same basic premise here. The drug is active for a period of time, and in the case of clopidogrel and prasugrel and ticlopidine, when the drug goes away, then you generally can have more platelet function again. These generally don't irreversibly screw the platelets up. But, still, how long they actually still have that functionality problem, most people would still recommend that with clopidogrel you give them 5 days before you go operate on them, if you have the opportunity. All right, and then recently what's come up is cangrelor and ticagrelor, right? So ticagrelor and cangrelor, you guys have seen these before, right? They may come back from the angio suite with these, especially if they've been declotted, right? And they didn't use TNK beforehand. These are nice because they are really reversible. The previous slide, they're not so reversible, but maybe a little. But these guys right here, you block the actual receptor itself, right? If you block that receptor completely, the P2Y12 receptor as opposed to the ADP receptor, because the previous one was the ADP receptor. If you block the P2Y12 receptor, this allosterically unblocks, and then they have clotting ability back again. So if you want to turn it on and turn it off, you can do that very nicely with these drugs. And then with dipyridamole and other things like that, you guys probably don't see a ton of dipyridamole or silastazole anymore. Maybe you do. I don't know. Do you guys see it much? Silastazole you're seeing a little more of again? Yeah, it's starting to make more of a mad dash there. So again, it's more of basically it's a CM derivative second messenger system that really ends up working here. And there's a disease process called Bernard-Soulet. And those people that have that have a problem with their GP2B3A receptor. And that prevents the platelets from being able to clog. So what people came up with is, what if we block it internally so we can make it so that this system doesn't activate, and it'll prevent this receptor from working like it's supposed to. Okay. EVD indications and ICP management for people that do have strokes. We'll go over some basics here. Elevate the head of the bed. The reverse is pretty obvious. You guys were all kids once. Did you ever hang upside down from the monkey bars? Or even from your couch if you weren't adventurous enough to hang upside down from the monkey bars? because you saw your sibling accidentally let go and fall to their near death. But while you were hanging upside down, you probably noticed that your head gets full of blood and the pressure goes up. Part of that's because of CSF, but you know what the real reason is? You don't actually have valves in the veins in your neck there. You don't have valves in your jugulars, right? So if you don't have any valves in your jugular veins, then the blood can actually go back the opposite direction, right? So there's a reason why that's there, right? So, because, I mean, imagine if you had those valves there, then you couldn't effectively drain from your head like you need to, so that would be really bad. Okay. So because of that, you rely on the ability of the veins to collapse enough to work almost like a valve. All right. Well, if you're trying to go ahead and prevent venous blood flow restriction to try to keep their pressure lower, you don't want to squeeze their neck. So if they have a C-collar on, it might be good if they're not moving around to loosen it a little bit, talk with neurosurgery, see if they can remove that, or whoever's on for spine, if they can remove that C-collar sooner rather than later. You don't want their head cocked like this. Try to have their neck straight, right? That's important. And generally speaking, I don't like them to put central lines, IJ central lines in these patients where I think their ICP could potentially become a problem, right? And the reason I say that is you don't really necessarily know how dominant one jugular vein is over another unless you've seen an angiogram, right? And if the right IJ happens to be the dominant IJ, it happens to be the dominant venous drainage out of the torcula, right? And you put a catheter in there and it starts to thrombose off, or they get a DVT, which every line that you put in a vein is going to have some level of DVT associated with it. Then you can imagine the pressure in their head is going to be artificially elevated from it. It's going to make life a lot more difficult for you to manage that patient. All right, temperature control. All right, we use a number of different drugs to control temperature. If they're intubated, it makes it a lot easier. If they're not intubated, you can still do it, right? And it could be something as simple as Tylenol or ibuprofen if they allow you to use ibuprofen. It could be something like bromocriptine or a dopaminergic, make them less likely to shiver. You can use meperidine. You know, certain narcotics are better than others at controlling temperature. Try to keep their PaCO2 in a normal range, 35 to 45. But if they're en route to the operating room, you can breathe them down. But don't use that as your strategy to try to keep their ICP controlled if you're not planning on a decompression. Why? Because you'll eventually be able to overrun that, right? Intubate if needed. EVD and ICP monitor, right? Your indications for an EVD or an ICP monitor are going to be the same as intubating, really. And only once I have that, except for en route to the OR, if someone's got a blown pupil and they have a big hemorrhage and I'm going to the operating room with the patient, I'll let them go ahead and give a slug of mannitol or a slug of hypertonic sodium. But the reality is that I see this happen frequently, and it shouldn't happen. People will say, well, you know what, I don't want to put the ICP device in. His sodium's 145, he's getting kind of sleepy. Let's just bump him to 150 and see where he goes. So they bump him to 150 and he looks better. Then, you know, a day and a half later, he's looking more sleepy again. They're like, well, let's bump him to 155. There's no pressure device in his head. He starts looking better again. Still got a bad headache, though. And then they bump him to 160. He starts looking better. And then all of a sudden, he falls off a cliff, and he blows a pupil, and he herniates. And bad things happen with that, right? If you had an ICP device, then you would have known that his ICPs were in the 40s. So rather than treat, just so that you don't have to drill a hole in his head. I mean, I'm not saying I want a hole drilled in my head either, but I'd rather people knew what they were doing and what they were treating rather than just kind of shooting from the hip. Now, if you've got a person you're going straight to the operating room for a big decompression on, totally get it. You can go ahead and give them the hypertonic slug if you want to. But then after that, I would drive your decision to run hypertonics or mannitol based on an ICP. And people really don't seem to think, I mean, if I asked you in the front, I'm putting you on the spot, I know. It's okay. You don't mind. If I were to go ahead and ask you, what part of the brain are you shrinking when you give them hypertonic sodium or mannitol? Are you shrinking the good part or the bad part? What would you say? You're right. Most people think it's the bad part that they're shrinking. But see, the bad part, those little sodium potassium ATPases that are responsible for keeping the sodium out of the cells and in the blood vessels themselves, they're not working. They're dead. That's what cytotoxic edema is, right? So if they're not working and you give them a whole bunch of sodium, thinking you're going to shrink the bad brain is false. You're shrinking the good brain to accommodate the bad brain, right? Your shift actually will probably get a little worse. And that's not necessarily terrible, it just depends, right? If you herniate badly, yeah, you're going to compromise blood supply. Everybody talks about the blown pupil, right? The third nerve being compressed. How many people talk about the posterior cerebral artery that's also compressed with the person who has the blown pupil? Not too many people. And the reality is when that person herniates, not only do they risk ripping their brainstem, which is a catastrophic event and causes a Dure hemorrhage that you'll see potentially, but on the way to herniating, they're compressing the posterior cerebral artery. So where they didn't have a PCA stroke before, now they do. So it's just something to kind of keep in mind. The cranny watch idea doesn't really work well, right? And someone else is going to be talking about surgery, so I don't want to rain on their parade. You can watch for a little while, but if you have more than half of the MCA distribution, stroked out in a relatively young person, someone who's under the age of 65, the Schwab data would say that you should probably go to the operating room and decompress them in a non-dominant hemisphere. Dominant hemisphere, then you get them to survive better, but the reality is many of those people just end up nursing home bound afterwards. So it's really kind of how you play the game, and what the family is willing to do, and what the patient would have wanted, and that kind of thing. So other things that you can do is you can do catheter-related evacuation of clot, or mechanical-related evacuation of clot. And so the MISTI trials showed that these people would get better sooner. But overall, at the end of the year, they ended up being in the same place. But if you can get them out of the ICU faster and get them rehabbed faster, I kind of still think that may have some significant benefits. So it's something to keep in mind. And this is the fun part, right? This is taking their head apart. Now, I like my field not quite this bloody, but the reality is that if they're on a blood thinner and you're taking their head apart and they have an intraparenchymal hemorrhage, it kind of is, you can give them what you can give them to reverse them, but it's still going to be there. And this is not one of those things that you do minimally invasive. What I showed you before was minimally invasive for a reason, right? You put a catheter in and you suck out the mass lesion so that the brain can kind of relax back into that space. It'll be swollen afterwards, but hopefully it's not so bad. But if you end up doing a decompression, you don't want like a small decompression, right? Because what ends up happening in the operating room when you do that, if you have a small decompression, is that some of the brain gets trapped behind the skull and other parts of the brain aren't trapped behind the skull. So the skull is here, brain is here, some of the brain comes out like this, and when it herniates out, it rips away from the stuff that's behind it or trapped behind it. So all those little nerves get torn up. So a minimal decompression when you're doing a hemicranie is a bad move. You want a very large flap that you take off for that. But if you could do it with a catheter and save them the big decompression, and you could actually have less complication risk, that's a reason to do a catheter decompression or a mechanical decompression with a device. So we talked about what the EVD indications are, and there's certain caveats. Besides them having a low GCS, GCS less than 8, right? If a person has hydrocephalus with a clear obstruction by clot, it may be worthwhile going ahead and doing their decompression, okay, with a catheter. If you're placing a pre-op for one of those cerebellar hemorrhages, right, that's a reason to go ahead and place it, right? And an EVG drain often starts at around 10 millimeters of mercury, but quite honestly, it varies. If you have a person who has a subarachnoid hemorrhage, you might have them open to 20 or even clamped, right? Because the more transmural pressure differential you have, the lower you bring the pressure in their head, the more likely they are to re-rupture that aneurysm. So you want to wait until that aneurysm's fixed, and once that aneurysm is protected, then you go ahead and consider draining them a little bit more, right? And to be honest with you, the reason why EVDs and lumbar drains are nice is because they allow you to reduce some of the blood product breakdown that you have there. You're not going to suck the clot out with them, but as the blood breaks down, you can suck that out, and that's important. But one of the things I wanted to do at UW, and I really didn't have the opportunity to do, but we do a lot at MCW, is intrathecal nicardipine. And so, when I was at my previous place, people would go down for angios once a day, sometimes twice a day, and they might be going down once a day for, a couple of weeks, depending on how bad their vasospasm is. I can't tell you, with the intrathecal carding that we do, I can't tell you the last time I sent anybody down for an angio for vasospasm treatment. So, quite honestly, these are other things that you can do. You have access once you have an EVD or a lumbar drain to actually do this kind of stuff. Okay? So it's just something to keep in mind. Now, device placement's important. I'm not expecting you all to be drilling holes in people's heads, but I do think it's important to look at something very important in this drawing. Everybody thinks that when you put a device in, you're measuring the pressure of the whole brain, and that's false. If I put the device here, I measure the pressure wherever the tip is, right? So if I have an ICP monitor and it just goes right into the cortex superficially, I'm measuring that part of the frontal fossa, right? I'm not measuring the middle fossa. So if I have a big temporal hemorrhage and I have a device sitting up here, the device up here could say, oh, the pressure's 25 millimeters of mercury, and here it's herniating the person and ripping their brainstem. So just know that when you put a device in someone's head, you're not measuring the global thing, and surely you're not measuring the posterior fossa, right? Because if you have a big hemorrhage in the posterior fossa and it's smashing their brainstem and they're not awake or doing anything, and you put the EVD at the top, the reason why you put the EVD is because you're going to go ahead and decompress the bottom part over here, take the bone off, maybe take the clot out, give it an ample room to expand, so it's not crushing the brainstem, it's not crushing the brainstem's blood supply. The reason why you put the EVD in those patients is because they develop hydrocephalus, and you don't want them to develop hydrocephalus. And in the operating room, you don't want the brain to be shooting out at you under pressure, so if you can decompress them above, that's helpful. The other thing that's important to recognize is the change in pressure waveforms. This is what you guys look like. You have P1, P2, and P3. P1, what happens there? Blood's getting squeezed out of the heart, it's going up your carotid artery, it gets into your brain. As it's getting into your brain, you haven't had enough time to get rid of some of that venous blood, some of that CSF, and so it reaches a peak at P1 because the skull is just not really all that compliant, right? It doesn't stretch under normal physiologic pressures, right? So as that happens, you hit P1, but now you have more flow out of your brain, out of your skull. Blood's still coming in, but CSF is starting to go and bounce to your lumbar cistern, right? And venous blood is starting to pour out, and everybody's happy. And then when it bounces in your lumbar cistern, it bounces right back up again, right? And as it ricochets back up, and blood is still coming into your head at that point in time, you get a little bump, and that's P2, right? And then you get some blood still coming in, but not to the same degree. Blood's still coming out. CSF is starting to egress right here. And then all of a sudden, the aortic valve snaps shut. Blood bounces off of the aortic valve, and you get P3 right there. Okay? And that's your cycle. Now here's the thing. If you become relatively non-compliant, the pressure goes down a little bit during P1 as CSF goes out, but it kind of has to bounce back up because there's no place else for it to go. And so what ends up happening is your P2 exceeds your P1. And this tells you that your brain in that particular circumstance is very non-compliant, right? It's not the brain itself in its compliance, it's the whole system is non-compliant. And that's something to let you know that there could be a problem coming up. Okay, so if you have an EVD and you don't have a big decompression, or if you have a big decompression and there's just so much swelling, it's very unusual. It'd have to be a very young person. But if you had that, it'd make you think twice about what's going to happen next. And you know what really happens next? It's interesting. You'll look at a patient who came in with a normal sinus rhythm. You know, their heart rate was 70s, 80s, everything is great. One of the earliest signs of Cushing's triad is an irregular heartbeat. It'll almost look on the ECG, on the rhythm tracing, or if you have an ECG, your ECG, like sick sinus syndrome, right? But it happens so fast on the screen. You'll see them. You'll see like their R waves get narrower and further and narrower and further, and so you'll see like a heart rate that's 50, then it's 80, then it's 50, and then it's 80, and it's all on the same screen, all within that's the same 10-second sweep. And that kind of lets you know the brainstem's getting pretty irritated. So it's usually like the tell right before something is going to happen. It's telegraphing it. Okay, good. And so that brings us really pretty much to the end of the talk. So in conclusion, many of the time you're going to be managing a really bad train wreck. But not all of them are going to be that way. But some of them are going to be that way for sure. And many of them, especially if you're at a tertiary center, are going to be this way. There's a lot of reasons for that. But you can't just go ahead and say there's just one way to manage it. There's a lot of different ways to manage it. Right? Bundled care was a way to try to say if you follow a particular way to manage things, you'll have a higher or a better outcome. And that's true. But really, it's about having a strategy that you can all agree with in your ICU and manage together. And I think the key to being successful is understanding the diagnosis and the management strategies and the styles and making them all work together for that particular patient, because there's really no single guideline that's going to tell you what is going to be the exact right thing to do all the time. The ICP management issues can be very basic or very complex, and really it's most important to control the things that are within your realm and call for help when you're not sure what to do next. And with that, thank you.
Thank you, Dr. Medow. We have time for questions, so please feel free to move to the mics.
Hello, my name is Matthew Johnson. I'm from UNC in Chapel Hill, North Carolina. Quick question, hopefully it's a simple one. When we're talking about the gaze deviation, so whenever I teach all my ICU nurses, I'm like, again, gaze deviation, if it's away from your symptoms, it's a stroke. But if you have a seizure, you gaze opposite way. I just don't know the why.
Sure. Let's look at it like exactly what you said. It's a good point. Frontal eye fields sit here. If I have a stroke on the left side of my head, normally with my frontal eye fields, both sides have tone, so they both have electrical activity going to the nerves that run my eyes. So they should look straight ahead, okay? They shouldn't deviate. Now, if I go ahead and I take this side out over here, I don't have tone from this side anymore to the muscles that would cross over. So as a result of not having tone on that side, the eyes look this way because there's tone from the muscles because of the nerves from the opposite side working. Does that make sense? Now let's flip it. Let's just say hypothetically, we said if I have tone on both sides, right? I have gaze looking this way. If I have a seizure, and now all of a sudden I have more tone on this side, for whatever the reason the seizure is. It could be a stroke, it could be a tumor, could be a bleed, which a stroke could be a bleed, obviously, right? A hemorrhagic stroke. If I have too much tone on this side, then what's it going to do? It's going to cause these muscles to pull this way. And so as a result of that, I look to that direction. Does that make sense? So it's got to do with your tone. So you look towards the stroke because everything crosses over to the opposite side, which then causes these muscles to look in this direction. And all that's actually driven by the sixth nerve nucleus first, and then it climbs up through the medial longitudinal fasciculus to the third nerve nucleus on the other side. And that's what controls you to go to make the eyes controlled to go together. Does that answer it pretty well, or? Go team. Any other questions? Thank you for your time. I appreciate it.
Thank you, Dr. Medow.